Welcome everyone to Four Eyes, the podcast brought to you by Young OD Connect. We give you a clear view into the young optometry world across Canada and the US. And we are your hosts. I'm Dr. Amrit Bilku.
And I'm Dr. Deepan Kaur.
And we're excited because today it's just going to be us two, just blabbing around on our podcast on the microphone. But we thought of having this episode kind of go around astigmatism because I know in my world that's been a topic of conversation for the last couple of weeks. And I know Deepan and I have done a lot of episodes just talking about our techniques for refraction and just kind of how it's changed over time as new grads and as young ODs. And I think we both prescribe differently now compared to, what we learned in school. But we really wanted to just dig into astigmatism today because it's a little bit different than the topics that we've talked about before. And we want to go through some cases of how we approach astigmatism now compared to how we were taught and how you guys are being taught in school right now, or if you just graduated you were definitely taught one way to prescribe for astigmatism, and there's so many nuances that come with it. So we want to share our thoughts and our experiences about it. So
I'm excited for astigmatism. Doesn't every single patient ask you about astigmatism though? Like
stigma.
it's like, or like stigism, or like, what's that thing I have? And you're like, astigmatism. And they're like, yeah,
Yeah,
that.
where it's
Should
really
I be
bad in the
worried?
sun.
Yeah. Am I
Oh,
gonna go blind?
yeah.
No. Like you'll be just fine. Actually, it depends. But yeah, you have an interesting case.
I guess we can say this is kind of like a case reflection series. I don't have all the specific data points in my face right now, but if you're interested in this case, I have shared this video on my Instagram profile. I share a lot of cases, by the way, refraction cases for pediatric patients on my Instagram. You can always go through my highlights. They're labeled cases 1 all the way to 4. And there's tons of different prescribing methods that I use there for hyperopia, myopia, astigmatism, amblyopia, all that stuff. So I recently posted a case. I've been following this little boy for over a year and a half now, who came to me in 2023 with a really high astigmatism. And the way that I prescribed, the way that I managed it, again, is very different than how we were taught in school. And when I posted it on social media, there's been a billion comments of just some curious and some being like, wow, this is so cool. And some that are very negative or just very judgmental and very analytical of like, no, you should not have done this. This is wrong. Even though the data points are right in front of you on that video to show that it is an effective way to prescribe. So I think Deepan got really interested too. So I'm excited to go through it because then even she was like, damn, you getting all the haters.
Yeah. Some drama. Oh my God. What's this
He
all
was
about?
scrolling all day.
Yeah. It's like,
Yeah,
uh,
so I'll go into it first, and then we can kind of talk through why I approached it that way and just what our experiences are with it. So, a typical run-of-the-mill case where a little 4-year-old boy comes in for his first eye exam ever. The parents really have no complaints. They just want to, get his eyes checked. And I think at 4 years old, this kid was really bright. So the parents were teaching him a lot. I think he was just about to enter JK or SK. So like he wasn't really even in school. He reads a lot. So he was already learning to read short words and he knows how to write and all of that. So, doing his dry retinoscopy, I think it was somewhere around, in the right eye, he had like minus 250 sil and in the left eye minus 350 sil with the rule astigmatism with a little bit of hyperopia, like maybe plus zero 0.5 or plus 1 in both eyes. Very typical case, I assume, that happens to all of us, right? We measure a high RX, high astigmatism, but the parents have no complaints, the kid really has no issues, and the VAs aren't terrible. Like for a 4-year-old, his unaided VAs were 20/40 in each eye. So, okay,
okay.
fine. If you're a traditional optometrist, that's pretty blurry, right? We want everyone to be at 20/20. And I have a mini topographer that comes as part of my auto refraction machine. So on the corneal topography, like his Ks were high. They were
Hmm.
like 44-ish and 45-ish in each
Yeah.
eye. But the topography was pretty clean. Like there were no hot zones, there were no red zones, nothing was uneven. I asked the parents about, eye rubbing.
Yeah.
They're like, absolutely not. We've never seen him rub his eyes. It's not really a thing. Obviously, keratoconus is always going to be one thing that we monitor for or that we just assess for and make sure nothing changes. But, what can we do to correct this kid?
Hmm.
And so I'll pause there for everyone to just kind of think about that refractive error, the entering unaided VAs, the situation on the cornea, and like, I don't know, deep on what would you immediately think at that point? I guess even thinking back to as a new grad, like what
Yeah,
was
that's what I
your
was
thought?
gonna say. So comparing to back when I was a new grad, yes, the 2040 vision would freak me out a little bit. And I'd be like, oh my gosh, like we got to get you to at least 2025 or something. So, yeah, I would smack on that sill correction and be like, all right, young 4-year old boy, try to, get down to this 2025 line. So yeah, like when I was a new grad, yeah, I would try to put on that sell. And if he eventually got to that 20 to 25 line, that's probably when I would have a discussion with the parents. Like, yeah, he probably needs glasses,
Mhm.
full time wear. Now, the 2040 vision is not really that scary to me, especially if the parents are not complaining about anything. I mean, I would still try to correct the sill probably to see if he gets down or to like a more improved VA. But I would have to think about it if I would prescribe anything. I might have done like maybe like a 6 month follow up just to see where he's at. Oh yes, and as a new grad, I would have definitely probably brought them back for a cyclo
Yeah.
refraction,
Yeah.
just to see if there was any hidden hyperopia, if there was something I was missing there. But now, but I'm not really even sure if I would bring this patient back for a cyclorefraction.
Yeah.
No.
Yeah.
I
I
would just see
didn't.
if there was any improvement in the vision. Um, is their binocular vision workup was all normal too? Like,
Yeah, so I didn't even, yeah, I purposely didn't even go through that, right?
yeah,
Because
okay.
I think that most of us would, we always get the auto refraction results, in the pretest before you see the patient. So, we always take the pretest information and already kind of make assumptions of, what's going to happen in the room. We already know what's going on with the patient. So even on the auto refractor results, it was really high, the astigmatism. My dry ret findings were pretty much matching the auto refraction
Yeah, and you
results.
said the VAs were the same in each eye too, which
Yeah.
made me feel a little bit more comfortable. If it was much higher in one or much like lower in one eye versus the other or worse, then I'd be a little bit like, oh, okay, okay, maybe I'll
Yeah.
bring this patient back for cyclo just to see if I'm missing anything. But yeah, 2040 each eye, I'm a
Mhm.
little bit more breathing out
Yeah,
and a
yeah.
little bit more
No,
calm in that
no,
situation.
like, anisometropic amblyopia, nothing
Yeah.
like that. And so, yeah, I didn't even talk about the BV results because I think most of us just are kind of on this automated system of, okay, we see a high refractive error, doesn't matter what the other testing is, we know we're going to investigate that refractive error and prescribe full time for
Yeah.
it. And so, yeah, that's not what I did as a behavioral doc and just knowing how to prescribe functionally. What we look into when we see a high refractive error, especially when kids have no complaints and no struggles in their day-to-day life and no ocular structures that look diseased or dysfunctional, um, most of those high refractive errors are coming from visual stress, meaning they are putting stress on their eyes from something like all the reading, all the writing, or they have internal stress that is now manifesting in their vision and in their refractive error. So it seemed like that's what the case was. This kid probably, I mean, loves to read. So
Yeah.
probably putting a lot of stress and fatigue on his eyes throughout the day, where now his visual system is getting tired, getting stressed out, but he wants to keep going because he loves to read and he loves to learn. So he is physically changing his visual adaptations to feel more comfortable with reading. And that's how the refractive error starts to kind of change over time sometimes.
You said it was with the rule astigmatism,
Yes.
right? Why wouldn't it be against the rule then if his focusing system was not under or if it's under stress? You would think more against the rule, yeah?
So, what I think is really cool, I've learned other theories about how astigmatism develops in behavioral optometry, which, if anyone's interested in learning more, you can always start with like Lens Power in Action by Dr. Kraskin or Optometric Management of Near Point Vision Disorders by Birnbaum, or like, talk to any BV doc or VT doc if you want to learn more. But there's other theories out there that our body posture, our center of gravity, our body balance, and how our body kind of shifts in space, or how we orient ourselves in space will start to change the way we perceive the world. And
Hmm.
astigmatism starts to develop through those changes. So, for example, if we are constantly in this state of scanning our eyes and our head horizontally, aka for heavy readers. Um,
Yeah.
and if we start to shift our body, our center of gravity a little bit more backwards or a little bit farther back, we can start to develop things like with the rule sill.
Hmm.
And then if we start to do vertical scanning, like we're constantly moving our bodies forward, our head and neck muscles are always moving up and down for certain parts of our day, we can develop more against the rule sill. And then if we have chronic head tilts, right? So if we're like musicians that are always playing an instrument on one side, if we have something like torticollis or some sort of a head tilt or a body shift to one side, we can develop some oblique sill.
Yeah. Okay.
I'm not totally right in all those theories because I'm still learning about it and I don't know how to articulate it properly. But there are other doctors out there who know exactly how to say it the right way. But then when you start analyzing these kids and you start seeing what their
Hmm.
habits are on an everyday basis, how they sit in the chair, how their body posture is, and how much stress they hold like internally, man, you start to really see the patterns.
Yeah.
Especially when, again, yeah, we learn that astigmatism mainly comes from the cornea and the lens.
Yeah.
Okay, if the cornea is healthy and the lens is healthy, where and their vision is fine,
Hmm.
where is it all coming from? And you mentioned that you had a case like that where like you had this guy with really high SIL, but he
Hmm.
was basically 20/20 or 20/25 vision,
Yeah.
right? It
Yes,
doesn't, the
I
math
had
is
this.
not mathing from what we learned
Yeah,
in optometry
this
school.
was when I was basically a year out of school, and I had this 25-year-old male come in, and his SIL was around a minus 3.5 in each eye, but he never really wore glasses, had no issues, a little bit of night driving issues, but and he told me, he's like, I'm aware every optometrist has told me I have a high astigmatism, but when I get the glasses, it's just really uncomfortable for my eyes. I feel nauseous when I wear them. I feel dizzy. It's just uncomfortable. It's not helping me at all. He was also without glasses or any correction, about 20/25 in each eye, and then 20/20 with both eyes open together. So that's what shocked me with this high of a
Mhm.
sill. How can someone see that well? But yeah, like he's obviously, I don't know, like now that we're talking about this, when I'm thinking about it more, maybe there was some sort of stress on his visual system where it kind of caused this
Mhm.
astigmatism. He was also with the rule astigmatism, so it wasn't against the rules, with the rule. But it just shocked me because I was like, I remember just seeing his results like through the auto refractor, and I'm like, minus 3.5 still. I'm like, this guy can't see anything.
Yeah.
How's he driving? How did he even get here today? And I even asked him that, like, without even listening. I was like, how did you even get here today? And he was like, I drove. Like, what do you mean? And I'm like, you what? Like without glasses? And I was
Yeah.
shocked. And then when I took his visual acuities, I was like, oh. And he's like, yeah, I'm just having a little bit of trouble with night vision, but I've always
Yeah.
had the doctors correct me for my astigmatism, and it's been too much, and I just feel really
Oh, of course.
uncomfortable. So can you please not do that to me? And I'm
Yeah,
like,
and I
okay.
encourage you guys to really like watch your patients when they're doing the VA chart, because people listening to this will say, well, yeah, with the rule astigmatism, you can get away with no, without correction if you squint.
Yeah.
Yes, but then watch your patient. Are they squinting that much?
Yeah.
Most of the time not. They are still capable of getting pretty good vision and being
But
functional
like
like, for what
even
they
with like
need.
minus 3.5 still, you have to have like tiny little slits to be
Yeah,
like
exactly.
squinting significantly to see the 2020 line,
Yeah,
2025 line. And he maybe he was squinting slightly, but I don't remember that. I would have remembered something like that. So
yeah,
it was just, now that we're talking about all this different ways to refract patients or how to think about it differently, it's kind of like I wish I asked him more questions about his,
yeah.
daily life to see like, oh, what's actually going on.
And do
But
more
it
BV investigation, right?
or yeah, yeah. But
Yeah.
like there were quite a few patients I had like that in my first or second year out of school where I was like shocked that their SIL was -3, -4, and they were like 2025 minus a couple
Yeah.
letters. And I was like, what is going on? How
Yeah.
did you just adapt to this and now you're just living like
And
I'm like, I want to
we
see what you see.
because we're taught that, with uncorrected astigmatism, you get a lot of glare, a lot of halos. Patients are squinting. We want to avoid that. We are taught that, prescribing the full amount of SIL is
Mhm.
important, and we have to do it to, 1 degree changes just to make sure
Mhm.
it's very precise and very perfect for the patient. Now, there are times where you want to do that refraction when you're measuring, their astigmatism for surgical correction. Yeah, sure. You
Yeah.
want to make sure that you have it right. For this 4-year-old boy, like moving on with this case, so we did the BV assessment as well. And what we would typically see with high with the rule sill in kids is either some sort of vergence dysfunction,
Mhm.
because again, they're doing a lot of horizontal scanning. And so you often find some sort of a divergence or a convergence issue, or you can find accommodative insufficiency. So
Mhm.
his cover test was totally normal at near and far. He had decent stereo for a kid, but he
Yeah.
had low amplitudes of accommodation in both eyes. So he had more so accommodative insufficiency, had to bring the card up closer when he was reading. He had that near working distance. He had more of a leaned in posture when he's reading because his kid was so cute and so bright and so smart. So he always wanted to lean in closer to things. So when we know that there's an underlying BV issue, regardless of what the refractive error is, the first thing you'd want to do in pediatrics is deal with that BV issue. So I already knew that if he has accommodative insufficiency, we're going to give him some low plus
Mhm.
for when he's doing things up close, when he's reading, when he's writing. And then in addition to the bifocal, I might not want to leave him at 20/40 vision
Mhm.
unaided. I want him to have some vision correction for distance,
Mhm.
um, just to maybe avoid future squinting and leaning in closer to watch TV and things like that. So I did give him a partial correction for distance. But the most important part of that prescription was giving the bifocal
Mhm.
because I want to make sure that accommodative system has been dealt with. And if we treat that accommodative system, get his accommodative system to function more efficiently, we're expecting that his far distance vision will start to improve on its own, anyways.
What if the far distance correction couldn't get him better than 2040? Then that's when I like, then what about being concerned about bilateral amblyopia or something like that?
That's a fair question. And so, what are you going to do about that, anyways, then? What would you do
That's
if
what I
you're
would start
right?
worrying because then I'd be like,
That is the
you're going to get more of this.
Like, yeah, so that's a great question. If you are increasing the refractive error and the child is not improving past 20/40,
Mhm.
what are you going to accomplish by pushing more still? If they're
Mhm.
still not getting more than 20/40,
Mhm.
you have not improved anything for the kid. You have just given a higher RX with no improvement in VAs. And you're also just crossing your fingers saying, okay, I'll see you in 2 months and let's hope that your vision gets sharper. And
Yeah.
it will because you are giving the visual system a high RX for the visual system to start to process things differently now. But you can do that with the lower RX that's also giving him still 20/40 vision.
Mhm.
If you give him a lower RX first and treat the any underlying binocular issue that's maybe holding his vision back from the
Hmm.
potential that it has, prescribe that and follow up in 2 months
Yeah.
and see what happens. Because you can always increase if you need to. And your RXs come with warranties. All of your opticals have a prescription warranty, within 1 month or 3 months or four.
Yeah.
Have them come back within your warranty period. Try a lower RX, see what happens. There's no harm, no foul. Because
Yeah.
if you are closely monitoring, you will catch whatever treatment plan is not working
Yeah.
for you.
That's true. Yeah. If
Yeah.
you are doing the regular follow-ups, that's true.
Yeah.
Hopefully
Yeah.
they're not lost to follow up and come back to you 5 years later.
Well,
But
then you do your due diligence and you call them and you
yeah.
document and that's all you can do, right?
Yeah.
That
Yeah.
happens that happens to all of us.
All of us. Yeah.
And so I ended up refracting him, I think with like plus zero point 0.5 sphere with minus 0.75 sil in both eyes. And I believe, I can't remember, I think he got down to 20/30 in both eyes. So
Like
he
each
was
eye 20/30.
in each eye.
Yeah.
Yeah, in
Yeah.
each eye. It was pretty equal.
Yeah.
So I said, you know what? I got him a little bit sharper for distance. I'm happy with him being at a 20/30 for a 4-year-old who's not driving, or operating heavy machinery.
Yeah.
I'm totally cool with that. I ended up prescribing plano minus 0.75 sil in both eyes at with the rule sil. And I don't know why I took out the plus zero point 0.5. I have no idea why I did that. Can't remember at this point. And then I added a bifocal. Full-time wear, come back in 2 months, see what happens. And so I followed him up
What
consistently,
was the ad that you put in?
a plus one.
A plus one. Okay.
I did that ad power based on my MEM retinoscopy and repeating monocular
Oh, okay.
accommodative amps.
Okay.
So with the plus one ad, he was doing great. Oh, I know why I did that now because I want him to have a plus one sphere at near.
Hmm.
If I gave him plus zero point 0.5 at distance, I did not have access to a zero point 0.5 bifocal lens.
Oh,
Yeah,
okay.
I'm limited to my bifocal starting at 0.75 and higher.
Okay.
And I think I usually just go with a plus one add.
Hmm.
So I had to do plano at distance,
Okay.
which is fine because the distance I don't care about as much compared to the near RX.
All right.
That's more important. And I think he came back like 3 months later in February of last year. And he was already getting to 20/25 vision in both eyes, in each eye for distance. His amps were improving, his MEM was improving, and he was totally comfortable with the RX. And dad was like, yeah, he's not leaning forward into the TV anymore. Everything else is normal. Followed up with him again, I think in like June and then December. And over time, with a year of wearing this RX, minus 0.75 sil, so only like half and a third of what he really is, he got down to 20/20 VA in each eye and 20/20
Oh,
UU at distance, 20/20 at near. Amps were normal, stereo was great, MEM retinoscopy was great, all in that same prescription.
so wait, before you go on more, I think a lot of the new grads listening to this are gonna think,
What
why
the heck?
wouldn't you know, for the first exam, why wouldn't you bring him back or do a cyclo refraction? Because
Oh
what if
gosh.
there's that hidden latent hyperopia? What if you're missing the true refraction? So I know we've talked about this many times before, like even in your Instagram posts, you mention it, but just for people who are shouting at
Newcomers?
us right now that are like, why?
Why
And
would
we're taught this in school, right? To like cyclo every child, especially if with vision like this.
Mhm.
It's like it was hammered into us, right?
Oh
To
yeah.
cyclo every kid. And so why again, Amrit, would you decide not to take that step?
I think it's important to learn about cyclo drops and understand what it can do and what data points it can give you.
Hmm.
But I think the problem is that it was hammered into us. So
Hmm.
we're kind of doing it blindly or just doing it because it's muscle memory and it's the motions and it's the fear of I have to do exactly what I was taught to do by routine, by the book. I'm not sure if some states or provinces like legally require you to cyclo every patient, but Cyclo
Hmm.
drops are giving you a data point, which is telling you what the refractive error is in the eye based on ocular structure
Hmm.
when there is no eye focusing involved. Like the
Right.
eye is not focusing at any point in space. It's basically dead. So it's
Hmm.
not functioning. Okay, cool. It tells you what that refractive error is. It is pretty much almost always going to tell you that the refractive error is higher,
Hmm.
even if it's higher by a quarter or higher by 2 diopters. That means that when my patient is not focusing, aka when they are sleeping with their eyes closed, or when they are underground, 6 feet
Yeah.
underground, or cremated, they're not using their accommodative system anymore.
Okay.
And that's when that cyclo-prescription is going to help them the most. So you can probably burn the glasses in the crematorium as well, because they're not needed. Honestly, I can't
Well,
even
I
think
think
of
there
the
was a
yeah.
comment you made before where, which resonated with me, where it was like you said, who which child walks around like
Yes.
this day to day? So you're not really testing how they're functioning day to day. It doesn't make sense to prescribe something like that when their accommodative system is nowhere near that.
Yes.
So why would you influence it that way and change it possibly where it can, like make it worse, right?
Yeah.
So I mean, and I feel like there is something to this too, because again, when I was a new grad, I would do the cyclo refractions. I still do some of them today when I'm
Mhm.
unsure, but I don't do them nearly as much. And if I saw a +5 in that cyclo, I would prescribe that,
Yeah.
maybe something a little bit lower. And I would constantly notice these kids at their follow ups just not really wearing their glasses all the time, or it wasn't really helping to improve the visual acuities, or
Mhm.
yeah, the parents would just be like, I don't know, yeah, they're not wearing the glasses, this and
Or
that. And I'm like,
adapting
I
to
don't,
it and then needing more. That's
yeah,
the
or
biggest
that
one.
too. And it
Yeah.
was just like kind of like a little frustrating at that point because you're just kind of like, what I'm doing here? And I feel like
Yeah.
a lot of people feel like that with kids,
Yeah.
especially new grads, because they're like, is this the right amount to prescribe? Should I cut
Hmm.
the sphere? Should I cut the sill? I don't know what to do. So
Yeah.
that's why I think it's just really confusing for everyone because even in
Yeah.
school it wasn't always like step by step. It was always like, yeah, maybe add a little bit more sphere here, or maybe like, yeah,
Yeah.
maybe not that. I don't know. So it was
Yeah.
never like always black and white. There was always a bit of gray
A
in there,
gray
but
zone.
I think we were never really taught like how to think about it or why their focusing system was doing that,
Yeah.
or you know what I
Yeah.
mean? Like it was always just to
So exactly.
band-aid the problem, right?
What I started to understand about the visual system is that your prescription, which should be no stress, like don't stress when you prescribe something to kids. However, this can make it sound really stressful. Your prescription is basically the building block or the foundational block for how their vision is going to function and how their eyes will function, right? So if you are going to prescribe your full cyclo or 1 diopter less than your full cyclo in both eyes for this kid, you'll notice that, yeah, most of the time in these cases, the kids come back and with the glasses on, their vision is excellent, right? They're
Hmm.
like, great, the kids' eyes are getting better, their vision is getting sharper, their strabismus is going down, they
Hmm.
have better attention, they have better focus, they're doing better in school. But you have basically let them build an efficient visual system on the basis or the foundation of that +4 that you've
Hmm.
given them. So that +4, let's say in both eyes, is the foundational brick that you laid for them to build their house of vision on top. So, which
Hmm.
is why every single time through and through, when you remove those glasses, that strabismus comes right back. Their vision gets blurry. Their attitude goes down. Their behavioral issues come back because you have removed the foundational brick and the house comes crumbling down. And that's also why They even, like I said, they function fine. They're perfectly normal kids after with their Cyclo RX that you've given them. And then they grow up and they become adults. And when you do their eye exam at 50 years old, they're still wearing that Cyclo RX pretty much that you've given them, and they still will probably have 20/20 or 20/25 vision. Yes, because they're wearing that foundation that is helping them to function.
Hmm.
So you honestly did provide basically almost like a crutch. You've
Hmm.
given them something to say, I can process my vision much better when I have this on. And I have not learned how to process my vision without it. But why not give them a lower foundation for them to learn how to use most of their vision themselves so that if the glasses come off, if the prescription gets lowered, they're still able to
To
function
function.
with and without it. And that's exactly what happened in this case.
Hmm.
Because and that's why I didn't cyclo, because yeah, cyclo drops give you a data point that says when my eye is not focusing, this is the refractive error I need. And
Hmm.
we are constantly always focusing. We're
Yeah.
focusing at 1 centimeter from our face. We're focusing at 1,000 kilometers away from our face. We are always focusing all the time.
Hmm.
So you need a prescription that will allow your eyes to focus comfortably,
Yeah.
not focus at all.
Yeah.
And that's why I did not cyclo because it wouldn't give me any other info for this kid because when prescribing astigmatism, in absence of corneal disease, undercorrecting is totally normal and actually super helpful for these kids because giving him a minus 0.75 in each eye when he started at minus 250 sil in the right and minus 350 sil in the left, he got to 20/20 vision in that prescription I gave him after a year. And then the bifocal also alleviated his accommodative issues, so he was able to focus really well with
Yeah.
less sil.
And we're talking about undercorrecting specifically for astigmatism.
Yes.
Myopia is a whole other
Yeah.
situation. So
Yeah.
don't think that we're like, oh, undercorrect for myopia patients, except
Mm.
we're specifically for
Talking
this
about
topic
astigmatism.
talking about astigmatism.
Yep.
So just
And
wanted to make that clear.
so what I loved about this case, if you guys go and watch the video, is what happened after a year. The kid was doing great with the glasses, and again, no complaints, no headaches, no squinting, no eye rubbing. Cool. You're doing great in school. You're 5 years old now. Keep up with the glasses. That was this past Christmas. And so I just saw him a few weeks ago. Actually, no, oh my God, in June. Whoa, it's August already. Um, I saw him back in June for another follow-up because I always keep check on these kids. And he wasn't wearing the glasses. And the dad was like, yeah, I don't know why, but like he hasn't really worn the glasses since January. So he's not wearing them. And I don't know. I mean, he seems fine. So I didn't know if it was like a big deal. And I had internal panic, okay? No matter how confident I seem with my cases,
You're
I was
like
like,
right now, you're like, I'm just joking. Everything I said, don't listen.
everything goes out as trash. I was like panicking. I was like internally, I was like, oh my God, he's gonna regress. His like vision's gonna be worse. The sill's gonna be higher. Oh my God, like I can't believe this. And on the outside, I was like, oh, that's okay. Like that's,
Mhm.
that's fine.
As we always say, that's
That's
okay.
okay.
Let's just try to figure it out now.
You know, us optometrists, we're always
Yeah.
the pushovers.
Yeah.
And surprisingly, he was unaided, I believe, like 20/25 in each eye and 20/20 OU, unaided at
Oh,
distance.
how long was he
And
not wearing his glasses for? Did
for
the
about
dad?
6 months then.
6 months. Okay.
Yeah, from January to June. So 5 to 6 months, he wasn't wearing them. And his monocular accommodative amps were better, with almost within norms, unaided. Cover test was fine, unaided. Stereo was good, unaided. MEM retinoscopy was a little off, like still a little bit of a lead because again, the kid loves reading. He loves writing and reading. And I did his dry retinoscopy, still has high sil, but I believe almost a diopter or 0.75 less than what
Less.
was even measured on dry ret a year and a half ago. And so I was shocked myself. Like, this kid has not been wearing his glasses,
Hmm.
and he started unaided at 20/40 in each eye and OU, and now he's 20/25 in each eye and 20/20 unaided OU.
Hmm.
And so I went, oh, what I'm doing works.
Hmm.
Okay, cool. Just
Yeah.
wanted to make sure. And so I was shocked myself and went, well, I mean, generally I'd say then, okay, you don't need any glasses anymore. The glasses
Yeah.
were pretty much therapeutic. They relieved most of your accommodative system. They helped your vision to become more efficient in its accommodation and binocularity. So now you're able to get sharper vision because with better binocularity, we get better visual acuity. However, I still wanted to give him an add power, like I still wanted a bifocal on him because he's still reading, and
Yeah.
it's only been 6 months. I mean, he's still going to go downhill if he doesn't change his habits, right?
Yeah.
So, and because that accommodation was better unaided than a year and a half ago, but not perfect. So I said, you know what? Just keep wearing your glasses because I just want to preserve like what's going on. Um, so the sill, the minus 0.75 sill in both eyes, I kept it the same. And he was 20/20 in each eye with that sill that he originally had. I put that +1 bifocal on him, and the +1 was too strong. So his MEM
Mm.
retinoscopy with the +1 bifocal was showing more of a lead of accommodation. So
Hmm.
that accommodative system is uncomfortable
Oh,
with
yeah.
that much plus at near. So when I cut it down to a zero point 0.5, his MEM was much better. And
Oh.
so I shocked myself and went, damn, I actually lowered his bifocal RX as well. So he doesn't actually need that much. And
Mm.
because again, I didn't have access to a zero point 0.5 bifocal lens, I ended up giving an anti-fatigue, which I wasn't happy about for a 5-year-old. I'd rather have a bifocal, but yeah, that was the only resource I had. So
Hmm. And
I
why
ended
do you prefer
up
bifocals over antifatigues for kids?
Um, bifocal lenses are life-changing for kids. They put the add power exactly where you need it in the lens for this little human being to look through because
Hmm.
they do not have eye movements independent of head movements, right? So you put a progressive lens in front of them or some sort of invisible blended add, they're not going to keep their head up and eyes down to
Yeah.
read like an adult. They're going to be moving their head all over the place. And when you blend those add powers, the maximum add is at the bottom of the lens, which is
Yeah.
really stupid. They don't even get the benefit of it.
Yeah. Yeah.
So you need that actual add power to be higher up. And the
Mm.
kids will then see the magnification. So you can teach them so easily to be like, make sure your book goes in the bigger zone, not the
Yeah.
small zone. And when you show them the big zone, they're like, oh, okay. They don't care. They go on with their life. They go play in the mud and they don't freaking care. So
Yeah.
it's not it's okay, guys. You can put kids in a bifocal. They will not be to as tortured as they would be if they had an eye patch on at school. So
Yeah.
put a
Yeah.
bifocal on them and they'll be okay. So yeah, it was a cool case. I shared that on social media and it's a lot of ODs just going like, what the
But
heck
I
are you
feel
doing?
like
Because it's so different.
even if some other OD saw this case and said what they would have done, there'd be a bunch of other comments saying, "Well, why wouldn't you
That's so
do this?"
true.
That because it's just not black and white.
Yeah.
I think it's just that's why these kind of discussions are important because it's like, well, what kind of worked for you here? What worked for this person?
Hmm.
Um, my other question was going to be, I guess you wouldn't be able to follow this method for someone who is an adult because they've already have that foundation set up for them where you can't really manipulate or like
That depends.
lower
It
their
depends
prescription.
on the patient, right? So it depends on their BV system. Are they someone who, like, people can be embedded with their prescription or
Hmm.
non-embedded, right? So you learn that in the OEP art and science course. but it's also a concept just in VT and functional optometry of just there are some people who are their eyes are I like to call them stubborn. Like they're just stuck in
Hmm.
whatever state they're in. So yeah, if you have someone who's worn the same refractive error full time for so many years, and their personality is maybe more high functioning, they
Hmm.
want certain things done their way.
Yeah.
Like engineers, like they want everything like to the T.
Yeah.
Never cut back the RX for an engineer because they, right? Like they want everything so perfect. You can't cut back for them because even
Yeah.
their BV system, their MEM retinoscopy is going to show you a lead all the
All the
time.
time.
So that it doesn't matter. But then for others, there is the opportunity because those are the ones who are probably low key symptomatic for something.
Yeah.
They're symptomatic for chronic headaches, or my eyes feel lighter when I take the glasses off, or I feel like I'm still squinting in these glasses, like it's just never perfect, or something. Something is always off with them. Those are
Hmm.
the people that are probably internally screaming for something different. And
Yeah.
typically, if they're in a high RX, it's something less.
Less.
And
Yeah.
so, yeah, you start cutting back that RX like a quarter at a time, every year, every 2 years, cut them back by a quarter or so. They're gonna start feeling relief over time. I do
Yeah.
that all the time in adults. Do you know how many adults are over prescribed?
Yeah.
Like,
That is true,
guys,
actually. I'll do that that's even with like older kids, like older
yeah.
teens who have that high plus and high sale prescription. I always end up cutting it
Hmm.
because they can still see 20/20 even with a much lower prescription.
Yeah.
And the parents are always like, oh my God, they got better. They
Yeah.
got better. And I'm like, well,
Kind
sure.
of.
I mean,
You could
and
just
they
act
like
like the
these are brand
magic
new
doctor
patients.
who
These
did
are
it.
not these are not patients that saw you for the first time. They're like, they went to a different doctor. This is the prescription, and you're like, oh my God. But then yeah, I always try to make it less and see. I'm like, I think this will probably be better.
Yeah.
But
Yeah. Happens
yeah,
all the time. So I'm glad I got to share that case. I hope you guys listening enjoyed it, have some curiosity around it. You can definitely go on Instagram or TikTok and watch that video. And then again, look through my stories and my case highlights. Like I have so many cases of undercorrecting. Undercorrecting for pediatrics, honestly, helps them a lot more than doing a full prescription. Doing your full cyclo RX or one diopter, 1.5 diopters less of cyclo, like you're gonna help the kid for sure. You're gonna prescribe the max RX that we were taught to do, and the kid's gonna get better, and you are going to think, wow, I did a great job. Like this kid now sees so much better. Keep an eye on those kids. Just keep an eye on them.
yeah,
After 5 years, after 10 years, see if their RX goes down. Because I
yeah,
guarantee you, most of the time, it will not, and it will increase, and you will keep increasing it to chase 20/20 vision on them. Because
hmm,
then after a few years, they won't be 20/20 vision in that high RX. And then when you bump it up again, they get back to 20/20 vision. So you're always going to be chasing what's the highest number I can give for the sharpest vision.
yeah,
If you do the opposite, what's the lowest number I can give for the most comfortable
functional vision.
binocular vision? Their
Hmm.
distance vision is going to improve, guaranteed. Because
Yeah,
if they can improve binocularity, they're improving depth perception, stereopsis, accommodation, and then visual clarity and fixation. So it all kind of ties in
ties
together.
in together. Yeah.
Yeah, thanks everyone for like listening in on this case. I hope you guys weren't like screaming at your phone or your car speaker, wherever you're listening to this.
I
There's,
think it's good to be open-minded. Let's just all
yes,
be a little bit open-minded. These are
yeah,
all things that are based on studies. This is not just
yeah.
something Amrit is
This is
pulling
not,
out
yeah,
of thin
I
air.
didn't wake up and just go, I'm not gonna,
Yeah.
give that sill today.
Yeah.
There's there's foundational concepts and theories and information and science behind all of it. It's all in behavioral optometry if anyone's ever interested. But I think just now, after Harbir Sayan posted his 2020 podcast episode with Dr. Bryce Applebaum, I think that stirred a lot of conversations as well. And we talk a lot about behavioral prescribing and functional prescribing here. And then Dr. Sayan's also given like a few other podcasts with some like VT
Hmm.
docs and behavioral docs. And there's just so much to learn where you don't have to be interested in vision therapy to prescribe functionally. I think that's the message that I'm always trying to get out there is that,
Yeah, over
yeah,
here, perfect example is me.
yes,
I'm
yeah,
not a vision therapy optometrist, but I try to be open-minded and think about why I'm refracting what I'm refracting, not just going step by step what we learn in school, but thinking about how am I actually helping this person
yes,
function day to day, whether they're a kid or an adult. So it's
yeah,
just thinking about things a bit differently.
yeah,
Yeah.
exactly.
Yeah. And on that note, thanks for listening to Four Eyes, the podcast series brought to you by Young OD Connect. Be sure to subscribe and follow us on Instagram or YouTube at Four Eyes Optom for more content. And we'll talk to you guys next time. Bye.
Bye.